Good morning, everyone. We'll get started since it's 8:05. I have the pleasure of introducing Dr. Justin Field. Dr. Field is an assistant clinical professor of medicine in the Division of Gastroenterology. He's an inflammatory bowel disease specialist and has a clinical and research focus on the needs of LGBTQ plus patients with IBD and anal cancer prevention in IBD. Please join me in welcoming him to hear more about healthcare maintenance in IBD.
Thanks, Steph. Good morning, everyone. So today I'm going to be talking about healthcare maintenance in IBD. These are my disclosures. So let's set the scene with a case. So you have a 30-year-old woman with severe left-sided ulcerative colitis who presents to the clinic to establish care. She was diagnosed 2 years ago and initially failed infliximab and was transitioned to upadacitinib and is now in clinical remission. She has a BMI of 17 and finally weaned off of prednisone after multiple 2-month courses. She is thrilled that upadacitinib is working and asks if there is anything else that she needs to think about now to stay healthy. So if you could, take out your phones or go to this website. So slido.com and enter this code, so 4176412, and we'll do a little poll. This is anonymous. It's just a word cloud. Your names won't be attached to it. But what healthcare maintenance items do you recommend for this patient? So she's a 30-year-old woman with UC diagnosed 2 years ago on upadacitinib. So anything you could think of that is important for this patient. So we'll give this a minute or two. All right, so answers coming in. Vaccines, COVID, flu. I see bone density, vitamin D, skin exams. So it seems like multiple people putting vaccines, so that seems to be a theme. Dermatology visit, pap smear, shingles vaccine, pneumococcal vaccine, the PCV20, ophthalmology. All right. I think everyone stopped typing. So big themes are bone density, DEXA scan, vaccines, PAP, and derm. So we'll go over that, and we'll go into the specifics of what the recommendations are for this patient and patients with IBD and sort of the why behind it. So why does healthcare maintenance matter? So people with IBD are at risk for infections, and these can be related to the disease itself and also the medications that we use. Metabolic bone disease and certain cancers, again, related to inflammation, but some related to medications as well. Many patients with IBD actually receive care only from their gastroenterologists. IBD is a complex, really all-encompassing disease, and people really spend a lot of time with their gastroenterologists. Immunosuppressive therapies that we use for IBD add complexity, can make these recommendations a little bit more complex and complicated. Preventive care improves long-term outcomes for patients with IBD, but it's found that IBD patients actually receive less preventive services than in patients without IBD. So part of this is a bit of a diffusion of responsibility and sort of knowing who's responsible for healthcare maintenance in IBD. So primary care providers might not actually be aware of the IBD specific needs or may really be overwhelmed and sort of looking to us to guide the ship. And GIs, as I mentioned, they often serve as the primary provider for people with IBD, but really this should be a shared responsibility. So a best practice would be to share your recommendations for healthcare maintenance with the patient, ideally written down, and also with the primary care provider, and then provide preventive care when feasible, or provide the orders or the referrals. Preventive care in IBD is a big topic, and it's nearly impossible to remember every single recommended healthcare maintenance item. So it's helpful to use a checklist. This is just an example of the Crohn's and Colitis Foundation, who published a checklist that arranges all the recommended items in an easy-to-use format that you can share with patients. You can go over it one by one, and patients can track what they're due for as well. So our major sources of guidance for preventive care have come from a couple different sources. The last major official guideline was from the American College of Gastroenterology back in 2017. And so this was called Preventive Care and Inflammatory Bowel Disease. But we have a very recent clinical practice update from the American Gastroenterological Association in April. And so I incorporated both. And so you'll see some recommendations from both of these guidances, as well as some other reviews and meta-analyses. So in this talk, I'll talk about some 5 major domains of preventive care in IBD. So vaccinations, cancer screening, metabolic health, infection screening, and mental health. Just as a caveat, I'm not going to go over colorectal cancer screening in IBD or micronutrient deficiency screening, because those are complex topics that could be their own grand rounds. So first, I'll start with vaccinations. So there's some key principles to keep in mind when recommending vaccines for patients with IBD. So all patients with IBD who are on immunosuppressive therapies should receive non-live vaccines, and this is in accordance with CDC, ACIP, and IDSA guidelines. However, live vaccines may be safely administered in patients on vedolizumab, which is really gut-specific, doesn't cause systemic immune suppression. It's important not to delay necessary care for administration of vaccines. So if somebody is flaring and they need to be on prednisone or they need to be started on an advanced therapy, the key is to start that care, and then vaccinations can come while starting or after. When possible, try to administer when the prednisone dose is less than 20, because this has been associated with increased uptake of vaccine immunity. There's no increased risk of IBD flare with vaccination. So this is a common patient concern, and we have data that can really support this. So for influenza vaccine, there's no increased rate of flare observed after 4 weeks of follow-up. For the COVID-19 vaccination, this has been studied and found that the rates of post-vaccine flare match the background rates of flare in people that hadn't been vaccinated. And then the inactivated zoster vaccination was studied out to 90 days, and there was no increased rate of flare after the zoster vaccine. So this can be helpful for reassuring patients that they can receive vaccines. It will not cause a flare of their IBD. So now I'll go into specific vaccinations. So the yearly influenza vaccination is recommended for all patients with IBD. And the why behind this is that people with IBD are more likely to contract influenza. So the figure to the right, the top one shows the annual influenza incidence per 100,000 persons in people with IBD versus healthy controls. And so you can see that there's a 709 per 100,000 person year incidence of the flu versus 459.7 in people without IBD. And another thing to note is that there's a higher risk of complications. So in the figure below, especially on the right, the hospitalization risk is significantly elevated in people with IBD versus healthy controls. Important to note that there's an impaired response to the standard flu vaccine with people that are on an anti-TNF or age greater than 65. So they should have the high dose vaccine. And then avoid the live, which is the nasal vaccine in people who are immunosuppressed. Moving on to the pneumococcal vaccine. So pneumococcal vaccination is recommended for all adult patients with IBD. There's an overall increased risk of pneumonia in people with IBD, and this actually precedes the IBD diagnosis, and is highest in the years immediately after diagnosis. So uh, the figure to the right shows the hazard ratio of invasive pneumococcal disease following a diagnosis of IBD. And as you can see, the rate is the highest in the first few years since the IBD diagnosis relative to a hazard ratio of 1. But it is persistently elevated in many years after IBD diagnosis. So this is related to the disease process itself, the immune effects of IBD, as well as the medications. So there is an increased risk of complications, especially with thiopurines, anti-TNFs, and corticosteroids. And people with IBD who are on anti-TNFs and who are elderly have an impaired response to the PCV23 vaccine. The latest AGA clinical practice updates recommends the initial PCV20 or 21, which is a newer version of the pneumococcal vaccine, which is recommended for all adult patients with IBD. And then for people that are 65 and above, give a subsequent dose after the age of 65. And then this figure just shows some specific recommendations for people that might have had the Prevnar 13 or PCV 13 or the Pneumovax shot before. So in general, if they've had it before, you still want to give the 20 or 21 and either 1 or 5 years after, depending on which vaccine they had. The herpes zoster vaccine is recommended for all adults with IBD. So herpes zoster is a painful dermatomal cutaneous eruption, and it carries a 10 to 20% chance of a painful post-herpetic neuralgia. So really worthwhile to avoid getting herpes zoster and helping our patients avoid it. There is an increased incidence of herpes zoster in people with IBD versus those without. So about a 1.68 incidence risk ratio in IBD versus non-IBD. Medications do increase the risk. So thiopurines, anti-TNFs, JAK inhibitors, and steroids have all been associated with an increased risk of herpes zoster. So the vaccine here is called Shingrix. It's a recombinant herpes zoster vaccine. It's not live, so it can be safely given even in those who are on immune suppression. So it's a 2-dose series, and if patients are on immune suppression, you want to give the doses 1 to 2 months apart. If they're not, then it can be about 2 to 6 months apart. So moving on to the human papillomavirus vaccine, this is the HPV 9-valent Gardasil, which protects against 9 serotypes of high-risk HPV and the types of HPV that cause genital warts. It's recommended for all adults, regardless of sex, up to age 26. And then the CDC recommends up to age 45 based on a shared decision-making process. So people who HPV is acquired usually early in life, but there are many different serotypes of HPV, and some people may not have been exposed to the high-risk subtypes. So really, it should be widely recommended, and it's a safe vaccine and can protect against some of these high-risk HPV subtypes. So HPV is implicated in cancers of the cervix, the vulva, anus, penis, and oropharynx. And it's really prevalent. So HPV is acquired by about 80% of the world's population at some point in their life. And in most people, it will be cleared. The immune system will get rid of it. But in the presence of inflammation or immunosuppression, it may not be cleared. And so that's likely why I'll get to that, but HPV-related cancers are increased in people with IBD. So the Gardasil is a 3-dose series. So it's given at day 0, and then 1 to 2 months after, and then 6 months after that, the first one. So moving on to the COVID vaccine. So the primary vaccine series and boosters are recommended for all IBD patients. There has not been found to be an increased risk of acquiring COVID-19 in people with IBD, but there is an increased risk for severe disease in patients that were on corticosteroids. It's possible that there's actually a lower risk for severe disease in people that are on anti-TNFs and possibly JAK inhibitors. But that being said, it's recommended to have the COVID vaccine and to co-administer with the influenza vaccine seasonally. And so moving on to hepatitis B, it's recommended to assess the hepatitis B vaccination status and then vaccinate as needed in people with IBD. And so hepatitis B reactivation can occur when people start biologics or immune suppressants. And this is actually associated with up to 5% mortality. So important to know what patients' vaccination status and hepatitis B status is before starting immunosuppressive therapies in IBD. The patients with IBD have been found to have a lower seroconversion with the aluminum 3-dose series. So it's recommended to use the 2-dose recombinant vaccine, which is called Heplisav, due to higher immunogenicity. So an approach that you can take for people that have not had a prior vaccination, they know they weren't vaccinated, then you can give the primary hepatitis B vaccination series, ideally with Heplisav B, the 2-dose series. For people that have been previously vaccinated, you still want to measure the hepatitis B surface antibody. And then if in many patients that will still be negative, or that will be negative. And despite this, they may still have immunological memory, which persists in the memory B and T cells. And so that can still mount a humoral and cell-mediated immune response when encountering hepatitis B. And so that's known as an anamnestic response. And it's a reliable measure of preserved immunological memory. So in patients that have a negative surface antibody, they should have 1 dose of the hepatitis B vaccine, Heplisav B being preferred, and then recheck the hepatitis B surface antibody in about 4 to 8 weeks, just to assess for that anamnestic response. Moving on to the respiratory syncytial virus vaccine. So RSV causes increased rates of hospitalization among patients with IBD, especially those above age 65. And so figure to the right shows the odds ratio for the risk of hospitalization due to RSV among IBD patients. And that risk is actually elevated even in younger groups, and that's but especially among those aged greater than 65. And so the recommendation here is that adults with IBD over 60 receive a single RSV vaccine. And then there's a separate recommendation to keep in mind for pregnant patients between 32 and 36 weeks. And that's to protect infants that are younger than 6 months. So I just wanted to touch on measles and the MMR vaccine, since measles is resurgent in the United States. You can see here on measles cases in the United States, we've heard in the news that there are many cases right now, but this has been something that's been going on for several years. There's no current recommendation to check measles titers routinely. And this is because we can consider immunity present if there's the following factors. So if patients have a documented age-appropriate vaccination with a live measles-containing vaccine, if they have known lab evidence of immunity, if they have had lab confirmation of measles, or if they were born before 1957. And so in these patients, you don't need to check titers because per CDC guidelines, they are considered to be immune. If the measles vaccination is needed, it is a live vaccine, so you should hold small molecules 2 to 3 days before administering the vaccine. They have a short half-life. However, biologics, you want to hold past the trough. One recommendation is 4 months, and then consider checking a level prior to administration just to ensure that it's very low. And wait 3 to 4 weeks after the live vaccine before resuming immunosuppressive therapy, because there's hypothetical risk that with this live vaccine that it could cause disease in immunosuppressed patients. So that was a lot about vaccines. So next, we'll talk about some cancer screening in IBD. So skin cancer is there are certain risk factors for skin cancer and IBD, and so we have a couple of different guidelines for skin cancer screening and IBD. And looking back to the ACG 2017 guidelines, they recommend a yearly skin exam for melanoma for all patients with IBD, and a yearly skin exam for non-melanoma skin cancer for patients on immunomodulators. The AGA practice update recommends a yearly total body skin exam specifically for patients on anti-TNFs, immunomodulators, and small molecules. So the table to the right shows sort of relative risks of skin cancer in IBD. So for anti-TNFs, definitely seems to be increased risk of non-melanoma skin cancer and possibly an increased risk of melanoma. JAK inhibitors, a possible increased risk of non-melanoma skin cancer. Thiopurine is a definite increased risk of non-melanoma skin cancer, and then possibly methotrexate as well. So a little bit about immunomodulators and non-melanoma skin cancer. So immunomodulators have been found to be persistently associated with increased risk of non-melanoma skin cancer even after stopping the immunomodulator. So this table shows the incidence rate of non-melanoma skin cancer for people who are actively on an immunomodulator, who have previously been on one, or have never received an immunomodulator. And so you can see the risk for either continuing the immunomodulator or discontinuing is relatively similar and well above those who have never received an immunomodulator. And so the why behind this, so 6-TGN incorporates into DNA, and it actually absorbs UVA, and that increases reactive oxygen species, which increases the risk of non-melanoma skin cancer. So moving on to cervical cancer screening, there's two guidances here. So the ACG 2017 guideline gave a stronger recommendation for enhanced screening for cervical cancer, recommended yearly cervical cancer screening for those on immunosuppression. Based on updated data, the AGA 2025 practice update recommends actually following the general screening recommendations for cervical cancer screening. And so these are for those age 21 to 29, cervical cytology every 3 years. For those 30 to 65, cervical cytology every 3 years, or high-risk HPV every 5 years, or co-testing every 5 years. And they acknowledge that certain patients you might want to consider enhanced screening. So people with a history of smoking, people on immunomodulators, anti-TNFs, and JAK inhibitors. Similarly to cervical cancer, HPV-related cancers are more prevalent in IBD, and so there's recommendations for anal cancer screening. The 2024 International Anal Neoplasia Society guideline recommends screening in patients with IBD on a shared decision-making process. The AGA 2025 practice update comments on this as well, and so they recommend a careful digital exam of the anal canal and visual exam of the anal canal during endoscopy, acknowledging that we don't often take a close look at the anal canal, but in patients with IBD, that is recommended. Because you can catch early cancers, and sometimes you can see some anal dysplasia on the colonoscopy. And they recommend special attention to patients with perianal Crohn's disease, anal strictures, people living with HIV, people who have known HPV, and those who have anoreceptive intercourse. This is a little bit more diving into the 2024 EANS anal cancer screening guidelines. So they divide into risk category A and risk category B. So the risk category A is groups that have been found to have a cancer incidence of above 17 per 100,000 person years. And so this is people living with HIV, those with a history of vulvar dysplasia or vulvar cancer, men who have sex with men above age 45, and those who have had a solid organ transplant 10 years from their transplant. Risk category B is elevated, but not as high as 17 per 100,000 person years. And so this is people with cervical or vaginal high-grade lesions, perianal warts, persistent cervical HPV-16, which is the highest risk subtype, and then those on other immunosuppression or on chronic systemic steroid therapy. And so they include IBD in this risk category B category. However, if we look at the established literature on anal squamous cell cancer in IBD, there are several studies that show that that risk, especially in perianal Crohn's disease, exceeds that 17 per 100,000 person year threshold for screening. And so in patients, especially those with perianal Crohn's disease, consider referral for screening for anal cancer. So how do we screen for anal cancer? There are three main modalities. The most important and accessible is digital anorectal exam. So this is feeling in the anal canal in all four quadrants of the anal canal for any palpable lesions, because early cancers are palpable. Dysplasia, though, is often not. Anal cytology is another tool that we use, and that's a swab of surface cells from the lining of the anal canal. And that can detect these pre-malignant high-grade lesions. However, the sensitivity and specificity is overall poor, so it's about 63% sensitive, 60% specific for that high-grade lesion. So high-resolution anoscopy is the gold standard test for anal cancer screening. It's analogous to cervical colposcopy. So it uses acetic acid and iodine solution to highlight these abnormal areas that, especially the high-grade lesions. And so it's a 15 to 20-minute procedure. It can be done in the office, possibly in the endoscopy suite if the materials are available, or the OR. And the good thing about HRA is that it's diagnostic, but also therapeutic. So if we see those high-grade lesions, we can treat them. And that has been found to decrease the rate or the risk of anal cancer. And this is the best choice for highest risk groups just because it's the most sensitive and specific. So here at UCSF, we looked at the referral rates for anal cancer screening among people with IBD with additional risk factors, so not just IBD. And we found that many IBD patients had other risk factors that should prompt anal cancer screening. And so this figure shows the percent of those patients who were referred for screening who had those additional risk factors other than IBD. And so you can see the rates of referral for screening were overall very low. So the highest rates for screening were in those living with HIV, and that's appropriate because that is the highest risk factor. But in other people with IBD and other risk factors, there was overall low percentage of those that were referred. So this demonstrates that likely more awareness is needed of the risk of anal cancer and recommendations for screening, because having multiple risk factors likely compounds the risk of developing anal squamous cell cancer. So moving on to metabolic health. So bone density screening is recommended in people with IBD. And this is because there is an increased risk of fragility fractures among those with IBD. As you can see in this figure, that risk is even present in those at younger ages. This is likely due to factors like malnutrition, malabsorption, calcium and vitamin D deficiency, corticosteroid treatment, and the inflammatory process itself. So bone densitometry, which is called DEXA scan, is recommended in all IBD patients with any of the following risk factors. So low BMI, less than 20, those who have had greater than 3 months of cumulative corticosteroid exposure, people that are current smokers, postmenopausal status, and hypogonadism. And so if low bone density is identified, then patients should be linked to primary care or endocrinology for treatment of low bone density. Touching on infection screening in IBD. So important to keep in mind that there are universal screening recommendations for HIV and hepatitis C. So the USPSTF recommends one-time screening for all people aged 15 to 65, and then repeat this as needed based on risk factors. Also keep in mind that PrEP, which is pre-exposure prophylaxis, is available and indicated for those with high-risk behaviors that for exposure to HPV. Hepatitis C is recommended to check for. So the USPSTF recommends screening for all adults aged 18 to 79. This is an update in 2020 from the prior 2013 recommendation that recommended in those with risk factors or that 1945 to 1965 birth cohort. But now really we should be checking for hepatitis C in all of our patients age 18 to 79. Also keep in mind latent TB screening. The rates of TB reactivation are increased, especially in anti-TNFs. So check for latent TB in those starting anti-TNF agents, JAK inhibitors, IL-23s. And so the initial screening is with an interferon gamma release assay, or the IGRA. And finally, touching on mental health and IBD. So there is an increased prevalence of anxiety and depression among patients with IBD. You can see in the figure to the right there, these rates are significantly above those without IBD. So this table shows the rates of anxiety, depression, and other mental health comorbidities in the general US population compared to the general IBD population. And the lifetime prevalence of major depressive disorder among patients with IBD is estimated at about 27.2%. And the prevalence of anxiety disorders is very high at about 40 to 50 lifetime prevalence. Higher depression scores are associated with decreased treatment adherence, higher disease activity scores, and lower quality of life scores. So important to be aware of and screen for in people with IBD. So there's multiple tools available for screening. So for depression, some commonly used tools are the Patient Health Questionnaire, PHQ, or the Beck Depression Inventory. And then for anxiety disorders, a common tool is the Generalized Anxiety and Disorder Scale, or GAD. So this flow sheet, this flow diagram shows a screening algorithm. So using one of the tools like the PHQ, BDI, or GAD-7, if there is a positive screen, link patients to mental health resources and sort of be aware of your resources that are available. If suicidality is identified, then it's important to arrange crisis care, and so refer to the ER or other crisis care. All right, so putting it all together, let's go back to the case. So we have our 30-year-old woman with UC in remission on upadacitinib. So want to recommend a yearly flu and COVID vaccine, pneumococcal vaccination, herpes zoster vaccine, HPV vaccine, hepatitis B serologies, a yearly skin exam, cervical cancer screening with PAP, and a baseline DEXA scan, HIV and hepatitis C screening, and mental health screening. So in summary, you should use a health maintenance checklist or EMR prompt to help remember everything that needs to be done and keep track of it. Review preventive care at diagnosis, annually, and before starting new therapies. Administer non-live vaccines for those on immune suppression. Collaborate with patient's primary care doctor or provider, dermatology, OB-GYN, and infectious disease as needed. And really it helps to communicate the why behind the recommendation. In an era of a lot of skepticism about vaccination, really being the experts and knowing the why is important. So thanks for your attention and happy to take any questions.